Good afternoon and welcome to this Australian Centre for Value-Based Healthcare webinar. I'm Alison Verhoeven, Chief Executive of the Australian Healthcare and Hospitals Association, and it's my pleasure to be your host today. Before we get underway, I'd like to first acknowledge and pay respects to the traditional owners of the land on which we meet, wherever you may be, and to pay our respects to their elders past and present. I also extend that respect to Aboriginal and Torres Strait Islander people joining us today. We're joined today by Jay Rebbeck, Managing Director of Rebbeck Consulting, a healthcare consultancy which is focused on primary health commissioning and health reform and is regarded as an international expert on primary healthcare commissioning reform. In this webinar, Jay will be exploring outcomes-based commissioning using a practical case study, including how you define commissioning for outcomes and how you measure and drive outcomes for people with diabetes. Jay has very kindly agreed to take questions during the webinar, so if you've got a question, please type it in using your Q&A section at the bottom of your screen, and we'll work through those questions during the interview. And with that housekeeping out of the way, Jay, welcome. Can you tell us a little bit about your experience in commissioning for outcomes?
Certainly, Alison, and just like to say, absolutely delighted to be on this webinar today. So thanks so much for having us. So yeah, just to answer your question, so my experience in health and government consulting is over the last 20 years, and the last decade I've really focused on healthcare commissioning, with a real focus since 2015 in Australia. We emigrated out here to set up Rebbeck Consulting Australia to really help build commissioning capability. But more specifically, in terms of commissioning for outcomes, which is obviously our focus today, I guess there's 4 bits of experience that I'll be leaning on today that I've kind of been using to synthesize the presentation and the questions we'll be taking today. So the first experience in Australia was around the Smart Skilled and Hired project. So working with our partners, Quantum Health, we've actually designed and evaluated what we believe to be the largest outcomes-based contract in Australia. So that's a $65 million outcomes contract to get young people into jobs in New South Wales. We're now into the 3rd year of that, and the evaluations show that that has delivered significantly better outcomes than comparable Commonwealth programs. And the critical thing about that program is 50% of the payment is directly contingent on getting young people into jobs for 6 months or more. So it's a proper, sizable outcomes payment contract. So that's the first bit of experience. Secondly, so New South Wales FACS, Family and Community Services, which has recently become DCJ, Department of Community and Justice. We did a 9-month piece of work with them last year where we developed a commissioning for outcomes guidance. So over those 9 months, we really spent a lot of time looking at all those range of different programs in what was FACS to really understand how we can kind of move that whole department to be much more focused on the outcomes of the clients and people that use their services. And that's led to us working with a number of their programs to help implement that guidance, including targeted early intervention, and specialist homelessness services. Thirdly, we've been doing a lot of work with primary health networks in Australia. So specifically, we did a piece of work with Brisbane South PHN last year to develop what we call a shadow outcomes contract, which is a way of sort of nibbling into the world of outcomes contracting with some really interesting lessons learnt. And then fourthly, we run a range of 2-day outcomes commissioning masterclasses, which we've been running with a range of organisations throughout this year. And we're looking to run a schedule of those next year with AHHA. So that's really the experience we'll be leaning on today, Alison. I think that was the first question, wasn't it?
Yeah, that's brilliant. So clearly commissioning for outcomes is much more than just a buzz phrase. How do you define it?
Yeah, thank you for that. So I'll be using a few slides as we go through to answer some of these questions. So I'll just pop that one up just now for people. Okay. So yeah, in terms of defining commissioning for outcomes, that's a brilliant question because I think it's important that we have a really clear definition of what do we actually mean by an outcome. And I think this is probably an area that people intuitively, everyone thinks they know what an outcome is, but I think when we're talking about outcomes in government and in healthcare specifically, it's important we have quite a tight definition. So we define it as changes that happen in the lives of people for the better. So it sounds very obvious, but there is actually quite a lot that sits behind this. So first of all, in terms of changes, we can be either seeking to have an increase in positive changes or a decrease in negative changes. So that could be, more people living longer, or it could be reduced numbers of people committing suicide, as an example. So changes can be more positive or less negative. Critically, we are talking about people when we're talking about outcomes. People, when you're in this space, people talk a lot about system outcomes and all these other types of outcomes. But I think, and although all those things are important, I think with outcomes commissioning, it's key that we focus in on a named client cohort of participants, of people, of users of the service that we're actually looking to achieve outcomes for. So that can be patients, consumers, clients, carers, families, groups and communities. And all of those people, I think, can be included in that group. But critically, whatever program you're looking to commission for outcomes for, you need to have a defined client cohort of people that you're aiming to achieve outcomes for. So a couple other things in the definition that I think are really important. The next is that the outcomes can be quite broad. The type of outcomes that we achieve for people, typically people think about things like conditions, health conditions, but I think it can be broader than that. So it can be, people's values can change, behaviours of people can change. And I think that quite broad definition is important. So, if someone's saying that they're now confident to manage their chronic disease by themselves without having to go to hospital regularly, I think that's an outcome. If someone's able to get back to work after a period of mental health, an episode of mental health, I think that's a good outcome as well. So it's quite a broad definition. And I guess it's also important, and we'll get into this later on, that we recognise the difference between those short, medium and long-term outcomes, recognising that in any health activity that we're commissioning, that we have a greater causal influence over those short-term outcomes than we do those longer-term outcomes. And inevitably, we need to work across government with other agencies to achieve meaningful long-term outcomes. I guess the only final thing I'd say on this, really, in terms of the definition, is that an outcome is quite distinct from an output. And I think that's probably the thing that in my time over the last 3 or 4 years, specialising in this, people probably most struggle with, is really that difference between an output and an outcome. And the way I think about this is, if you imagine standing up and having a line in front of you, on the other side of the line is an outcome, on this side of the line is an output. If there's something that has changed for you, so if you put yourself into the shoes of a patient or a consumer, if something has changed for that person in their body, in the way they either think or in their physiology, it's an outcome. If something hasn't changed for them, then it's probably an output. So if they've got a GP management plan, that's fantastic, that's really good, but nothing's actually changed for that patient. So you really need to be stepping into the shoes of patients and consumers to see if something has actually changed in their life for the better.
That's a really neat definition, that's stepping over the line. So how do the people who are on the line here, probably all people who are responsible for health services, potentially commissioning programs, how do they step over the line? How do they actually get started in the business of outcomes-based commissioning?
Thank you, Alison. Yeah, okay, so let's get into the detail of this, I guess. So look, I think from our perspective, the thing that we found most useful when you're actually trying to get into this commissioning for outcome space is to actually think about program logic or logic modeling. It's called different things. But fundamentally, we need to start by understanding the needs so again, I don't come back to this point I made before. We need to have a defined target client cohort, which is really clear who are we looking to achieve an outcome for. So that's the first point. And then once we understand who we're looking to achieve an outcome, we need to understand what are the unmet health needs of that population of people. What's the problem fundamentally? What's the health problem that needs addressing? So that's really the first thing that we absolutely have to do. And across the country, I regularly see program logics that don't have needs on the left. It just starts with inputs. And it's like, if you're not actually, if you don't have needs, you're basically a solution looking for a problem. And we're looking in healthcare to actually deliver solutions for actual problems that our health communities actually face. So it's really, really important that we start with the needs on the left-hand side. Now, the mistake that is often then made when people are developing program logic is what I call left to right program logic. People, A, often don't have needs, but B, they then go from left to right. So the classic way it would run is someone in Canberra will just sort of have some sort of good idea about how we should deliver some service. So, and they will say, right, let's go and deliver the service. You then, so it's the response is mandated. It could be, so I'm not going to give any examples here because I don't want to get in any trouble. But so response is mandated from the centre that something is going to be delivered across the country, and then people sit around scratching their heads, going, okay, I wonder what outcomes we could achieve if we put that service on the ground. Now, fundamentally, that's not the way we should be thinking about this if we're serious about outcomes. We should start with the needs, and before we're even thinking about what the actual response that we're going to put on the ground, the first thing we should be doing is looking at the outcomes. So we look at what will change for people. And like, spookily enough, when you actually look at outcomes, they are generally just a reframing of the needs. So if the need is that you've got patients with poorly managed diabetes, then the outcome you're looking at is them to be able to manage their diabetes. If you've got the need is that you've got high suicide rates in your community, then the outcome we're looking is to lower those suicide rates. So this whole process of doing program logic by needs and then outcomes is actually quite simple, because you'll see there's a certain symmetry to that whole process. Once you've got really clear what your short, medium and long-term outcomes are, then the next step is to then work out what your responses are. And this is where we really lean on the evidence locally, nationally, internationally, of what types of services do we know are really well causally linked with the outcomes that we're seeking to achieve, and then what's going to work in your particular setting. So if you're in a remote area with a high number of Aboriginal people, it's going to be a very different type of response that's needed in a metropolitan area with a mainstream population, just as an example. So that's really the sort of the fundamentals thing that we feel you have to get right is getting the program logic sorted.
So let's get really practical here. We know that there are a lot of people in Australia with diabetes who require our help and who require better program delivery in order to achieve better health outcomes. What's your take on this?
Thank you, Alison. Yeah, so diabetes is a really interesting example. I think it's, and again, it helps us get much more practical about this. So what I've sort of sought to do here really is just start to apply that program logic thinking from the previous slide and actually apply it to a community of patients with type 2 diabetes. So in this instance, we're talking about patients who have poorly controlled type 2 diabetes, who we know without appropriate intervention are at risk of losing their sight, their limbs and their mobility. So that's the need, and we could, any health jurisdiction could actually identify that target cohort in their community. So the next question is, what are the outcomes we're looking to achieve? So clearly the long-term, well, we'll start short-term. The short-term outcomes, we know there's really rock-solid evidence that if patients with type 2 diabetes can have well-controlled blood sugar levels, that's a really, really good short-term outcome that actually leads to a medium-term outcome of them retaining their eyesight, retaining their limbs, because we know people who have poorly managed diabetes are in real danger of going blind and having to have amputations. And so if we can keep control of blood sugar, we can maintain people's eyesight, maintain their limbs, and fundamentally that leads to a long-term outcome where they're going to actually maintain a much better activities of daily living, and their overall quality of life clearly is going to be significantly better. So those are the long-term outcomes that we're looking to achieve. So once we've understood the needs and we're clear on the outcomes, we then start looking at the types of responses that we know that are going to lead to that. And again, many of the people on the call will know this stuff better than I do. The types of responses that we know that lead to those sorts of outcomes are when you get GPs, endocrinologists, dietitians, diabetes educators, Aboriginal health workers, working together in those multidisciplinary teams, doing all the appropriate types of intervention around reviewing medication, helping those patients to diet and exercise, and then monitoring their lifestyle and how they're actually responding to that kind of services they receive. And we know that also, if you can actually get those patients to actually have a really clear care plan in place that is being actively monitored, and they're actively, jointly working to achieve, then all of those types of responses help patients to control their blood sugar levels. But what's interesting is if you look historically, what's happened in Australia, and indeed in many other parts of the Western world, is that there's been a real focus on particularly the inputs and the activities. So it will be very common for people to be paid to have these professionals in place and pay them on the activity. So every time they're seeing one of these patients with type 2 diabetes, they're getting paid for that. The problem is, if you just measure the inputs and activities, you have no idea, and you have no way of knowing, has anyone's life actually changed as a result of all of this busy work that's happening? So the aim of outcomes commissioning is to say, okay, we need to measure that stuff, but we also need to measure those short, medium, and long-term outcomes. So we know that actually, that way, we can actually, for any set of professionals who are working together for a particular cohort of patients, we can actually see how successful they are actually being at controlling those blood sugar levels in this instance. So really a couple of key points here. One is to some extent there's nothing new about commissioning for outcomes, because if people are already measuring a lot of information about how they're interacting with their services. It's just a change of emphasis, so that now we're placing a greater emphasis on those outcomes that are meaningful to the people that we're actually working with. And the other key point is, and a mistake that's often made in commissioning for outcomes is people think, all right, we're just commissioning for outcomes, we don't need to worry about all that inputs and activity stuff. That's not the case. We still need to know that we're identifying the right people, we've got the right skilled professionals in place, they are doing the right types of treatment, but as well as that, we then need to measure that the outcomes are ultimately being led and met.
So you briefly mentioned the paying for inputs and outputs, and we know that there are moves internationally and nationally to talk about paying for outcomes. What's the real difference between paying for outcomes and commissioning for outcomes?
Okay, so thanks for that, Alison. So really, this is a really critical distinction, I guess, through the work we've been doing has crystallized really. And that is, I think that there's this common misconception that commissioning for outcomes equals paying for outcomes. So basically, the way I think most people in Australia think, if you say, well, what is commissioning for outcomes? They would say, oh, right, okay, what that means is that you're going to take some proportion of any contract you've got with the provider and you're going to make that contingent on them achieving outcomes. So you're basically changing the payment incentives, and that's what commissioning for outcomes is. And this is a mistake that we've seen borne out in some really large scale outcomes commissioning failures in places like Cambridge and Peterborough in England, and in the Central Coast in Australia. It's a fundamental mistake that keeps on getting made, where people think that if you just change the payment mechanism, you will magically change behaviour and you will magically change care pathways and suddenly outcomes will improve. Now, pulling the payment lever is quite a blunt instrument. It can work, it can be really effective in the appropriate circumstances, but it's not always effective. So we define outcomes-based commissioning not as just paying for outcomes, but we define it as two discrete different things that happen in an order. So the first is, to commission for outcomes, you have to identify, measure, and drive outcomes. So we describe that as being compulsory, okay? And everyone should be doing this, regardless of what service that you have. If you can't identify the outcomes for your patient cohort that are being delivered, then you're not ultimately able to identify the value of the healthcare intervention, because obviously value equals outcomes over cost. So we have to identify the right outcomes for any health service intervention. We have to measure those outcomes, and then we have to use that information in a really intelligent way to actually encourage our providers to actually deliver better outcomes. And just naturally, when we're talking about health service providers, we have a competitive group of individuals who want to improve their outcomes, and we're all motivated by improving outcomes. It's what gets healthcare professionals out of bed. So if you give them the right information, they naturally will try and improve the outcomes for their patient cohorts, but only if they've got the information. If they haven't got the information, then obviously they can't know. So that's the most important thing. And then secondly, once you've done that, you can then start working out when it makes sense to pay for outcomes. On the next slide, I kind of just explain that in a little bit more detail. Really, what I'm, I guess, expanding on here is basically saying, although measuring and driving outcomes is like I say, essential, outcomes-based payments is only appropriate in certain circumstances. So I'm just going to sort of talk you through briefly the types of circumstances. Actually, do you know what? I'm going to come on to that later, but later in the presentation, if we've got time, we'll come on to when we think it's appropriate to pay for outcomes. But that's really, just to answer your question, that's the real distinction. Right.
What about carrots and sticks? Do they work?
Yes, they do. I think there's really two ways. I mean, I've actually got a slide on this later on the pack, which I can kind of, let me just take you on to that one, because it's actually answered that question quite nicely. I think in terms of carrots and sticks, I think the way that we tend to find we get the best when we're talking about paying for outcomes, the best incentives is when we're using carrots. Like just generally speaking, and I can tell you that from having 3 kids under the age of 5. Rewards seem to be a lot more effective than punishment. I think what we find in any payment mechanism is if you can basically see it as an upside, then you're generally going to find it easier to incentivize providers. But you can either have sticks where you actually are going to reduce the amount of payment on outcomes, rewards where you actually increase the amount of payment, or you can have a blend of the two. But it's important that that's really relevant to when we talk about paying for outcomes, which, as I sort of mentioned before, isn't always completely relevant.
So let's go back to our diabetes patient and flip back a couple of slides back and talk a little bit more about how all of this will be applied or could be applied in a scenario where you are commissioning for outcomes for people with diabetes.
Beautiful. Okay. So look, I think taking the previous example that we were just looking at, I think what we would do is we would basically co-design the program logic. So that the first thing I would sort of mention, whenever you're doing your program logic, is you really want all the people who best understand the topic area around the table jointly working out what are those outcomes that are meaningful to patients. So that includes patients themselves. So we'd want them involved in the co-design. We'd want the clinicians involved, all those subject matter experts, basically anyone who might be involved in the care, and it could include family members, and those people in management who need to understand it. So we're going to co-design this process. So what we're showing here on this slide is an example of what might come out of the co-design process. And what you can see is we've actually identified a set of specific KPIs across the program logic. And those are the KPIs that we would be tracking to make sure that the patients, so type 2 diabetics, are basically working through that kind of experience. So another way of thinking about program logic is essentially what it really is a patient journey through the health system. So what we're doing with the program logic is we're measuring KPIs that are showing that person's journey through the health system and actually seeing, are they getting a good outcome at the end of it? So the KPIs, as I've shown on this slide here, are examples of the types of KPIs that we've been measuring to know that people are coming into contact with the right types of professionals, they're getting the right types of treatment and counselling in this case, they're getting the right kind of plans in place, the right sort of team care arrangements, and then that we can actually see that that's having an impact on them being within the recommended HbA1c levels. And then you can see some of the KPIs there that are showing that they're, the number of patients with peripheral neuropathy, the percentage of patients maintain their eyesight, and then the quality of life indicators. So really what we'll be looking to do is actually track those KPIs. Now, look, what I've done just on the next slide is given an example. So let's pretend we've got say, 2 sets of multidisciplinary teams in 2 locations, and one's doing a really good job and one's doing a really not such a good job, in this model, it'd be quite easy to see which set of professionals are actually achieving really good outcomes and which aren't. But you'll notice, so it's on the left-hand side, if the red line is the target that's been set for a provider in terms of their KPIs from needs, activities, outputs and outcomes, and on the blue bar basically shows what their actual performance is. So the first thing to note is that, and this is really important, so we talk about the funnel in program logic and in performance monitoring, because inevitably you can't achieve outcomes for your whole patient cohort. It's unusual in most health initiatives for us to be able to achieve the desired outcomes for everyone. So we know that there's losses because of, you can identify the people, but you can't always get them to attend. So you can't get the activities, and of those, you know, for all your best endeavours, you can't always achieve outcomes for everyone. So we know, and that's predictable, but the question is to set some targets that actually allow for the fact that we're not going to get everyone to outcomes, and then see how people are actually tracking through that funnel as you're running a project. And this type of approach is an approach that we've used on a range of contracts. And it's really, really helpful because of the problem, if you only measure the outcomes at the end, is that you've got no early warning indicators. So if the outcome it might take 6 months or 12 months to achieve, if you just sat there waiting for 6 to 12 months and see, oh, have the outcomes been achieved? And then they say, oh, they haven't. Oh, by the way, we never were able to recruit someone in the first place to actually deliver the service. It's like, well, it would have been good to have known that 6 months ago. So that's why it's so important that we are tracking those earlier indicators, so that we can see that our providers are doing all the right things that they need to do that we know will over time lead to those outcomes being achieved.
So I know you've differentiated between the commissioning for outcomes concept and the payment for outcomes concept, but the reality is that, you know, if a decision maker and a funder looks at a slide like this and sees, you know, considerable variation between a number of providers, they're going to need to start thinking about what that means for them as funders. So
absolutely,
how does this become real then for funders thinking about how they're going to pay for different types of providers?
So I think I'd answer that in a couple of different ways. So I think the first point I'd make is the point you're alluding to at the beginning there is that if you don't necessarily need to pay for outcomes to be able to make really significant changes, and you can also make changes in future contracts. So in this example, so this slide we've got in front of us, we've got one provider that's doing a great job, they've achieved all their targets, another one that's not achieved their targets. Now, although you might, if you've got a contract, you might pay them to the end of the contract. When it comes to the next set of contracts with that provider, clearly, provider 1 is in a much better position for you to deliver that service in future than provider 2. So I think, and interesting, we've actually seen this with Smart, Skilled and Hired, where halfway through the program, we had 11 of the 12 providers who had been getting lots and lots of young people into jobs, but one provider, even after sort of 2 years, they hadn't actually got a job for any young person. So we actually decommissioned them. We basically said, look, your model's not working. And when we get, you know, this didn't happen overnight. This was over a period of time, lots of discussions, and we mutually agreed that they just weren't, the model wasn't working. And what was good about that is that we were able to then, in that instance, use that money to then reinvest it in some of those other providers that are delivering better outcomes. So that's an example where paying for outcomes can be quite useful, and it's also important to recognise for a value for money for a taxpayer, that's actually quite a good outcome. And sorry, Alison, there was a second part to your question. What was the second part?
Well, really about the circumstances in which a funder decides that they need to exercise that lever. So, and I know you've done some thinking about favourable and unfavourable circumstances and how that might shape some of that decision making.
Yeah, okay, thank you. So, so I think what we sort of think about really, if we do want to pay for outcomes, and if we're thinking that this is an area, and I know there is a lot of appetite to move in this direction, then we need to work out where does it make sense to pay for outcomes, okay? So and this came out of the work we were doing with New South Wales Facts, is what we started to identify is there are some circumstances where it actually really does make sense to pay for outcomes. So some of the examples are, if you've got a provider that's actually got really deep pockets with deep cash reserves, then that's important, because if you're being paid on outcomes, you have to wait for the outcome to be delivered. So someone's got to hold the risk in the intervening period before the payment's actually made. So you do need providers that have got sufficient cash reserves to actually fund their way through that gap. Secondly, you want providers that are actually financially motivated and actually have some sort of risk appetite to get outcomes payments. So fundamentally, some types of organisations just aren't that motivated financially. So, and some of the very small NGOs that we've been working with the last couple of years, we don't believe that they are ultimately that financially motivated. So, and the risk appetite is vanishingly small in some examples. The third thing is, have they actually ever done this before? Okay, so if you're dealing with, again, some of the larger corporates, larger NGOs, they understand that it's really important that for their boards and their shareholders, that they have to be able to demonstrate outcomes. So some of them are really quite ahead of the game in this space and are already measuring outcomes. And so, again, if they've already got the right sets of outcomes that they're measuring, that can be really useful. But if they've never done it before, then there's a maturity gain needed. So that's really speaks to both the sophistication and the experience points. And then the other couple of points I'd make is, it is easier to move to an outcomes payment model if you're starting up a new program, because there's no legacy or historical expectation of what sort of payments. So and again, with Smart Skill and Hire, that was a good example where it was a new contract, so we were able to do that. But that's not normally the case, because a lot of health services have obviously been running for many years. And then the final point is, you do need to get some consensus about what outcomes are meaningful, because if everyone's having an argument about what's actually important, then it's going to be very difficult to translate that into contracts. So that's why the co-design approach that I talked about before is so important, so that all of the people who understand the needs of a particular cohort are in agreement about what the outcomes are to measure. And so look, if you've basically got a situation where you have providers that are broadly on the right hand side, so you've got very favourable circumstances, then I would suggest having quite a large component that is outcomes, that's contingent on outcomes. Whereas if you've got a provider, going back to the previous slide, that's much more on the left hand side, then I would have either a very small outcomes payment, or indeed, and this is a really important point, no outcomes payment at all. And this is really important. You can achieve fantastic improvements in outcomes by just measuring and driving outcomes without changing any payment mechanisms whatsoever. And so I do, and like if you look at the Martini Clinic in Germany and how they've just transformed their prostate cancer outcomes for their patients, they're not paid on outcomes, and yet they deliver the best outcomes in the entire globe. And this is a really good example of how we can really seek to measure and drive outcomes before we move as a precursor to stepping into the outcomes payment space.
Jay, we've got a couple of questions online, but before I go to them, I just wondered whether you might show your next slide, the illustrative payment mix
oh, yeah, sure.
that I know you have, just so that you can explore that. Just no, not that one. A little bit further on where you. Sorry, was that the one that showed with your percentages? Yeah, that
yes,
one.
The percentages one. Yeah, yeah.
Thank you.
So this is just like an example that I was putting together, and as you know, this is not by any this is no huge science in this, but really all I'm saying conceptually about how you might move to outcomes payments is you would already be paying your providers typically on some sort of mix of input funding. You might even give them some funding at the beginning of a contract, activity funding in hospitals. The majority is on activity funding. And there's, you know, incentive payments often to achieve outputs such as diabetes care plans. So, and again, there's a whole, I'll give you a whole separate presentation on this about how you introduce the actual payment. But what I would say is I recommend starting gently and easing into outcomes-based payments, because some of the big failures that we've seen in this space that I mentioned previously they tried to make this 10%, that was like 30, 40 or 50%. So you can start quite a modest proportion. And you can even introduce outcomes payments in a shadow form. So you can actually run it for a period of time with the previous payment mechanism. And you can actually say, if we'd run an outcomes payment mechanism, what would the payments have looked like? And we've done that in a couple of places, which is sought to kind of build confidence of both the commissioner and the provider. And then once you get the confidence that the sky's not going to fall in when you change the payment mechanism, you can then introduce that in a later point.
Thanks, Jay. We've got a couple of questions online, and they're basically fairly similar question. That is, how do you actually get a conversation going with your colleagues, with providers, with management about applying this type of model, particularly in a public healthcare setting?
Yeah, so I think I would firstly sort of say this is a very significant trend that we're seeing across the whole Western world in healthcare, and indeed across government more broadly. So the whole movement from volume to value is something that anyone that works in healthcare would have heard about, and everyone knows that there's a big direction of travel. So I think recognizing that there's a significant trend in this direction, I think there are some really good examples of institutes that actually focus on this. Obviously, AHHA, you guys are increasingly, you've got your value-based healthcare institute you're setting up, but you think got places like ICHOM, the International Consortium for Health Outcomes Measurement. So all of those organisations provide lots of kind of examples of where moving to outcomes is actually really effective. And I think there are some good case studies that can be pointed to. So I've talked about Smart Skilled Hired. You've got the Victorian Cardiac Outcomes Register. So there's really good examples. And I think when you try to have that conversation with your colleagues, pointing to some of those examples about actually how measuring driving outcomes is really effective, is really helpful. I mean, the next thing I was going to say is we do run a 2-day course on outcomes-based commissioning, and we have obviously a whole load of insights, information. We talk about the case for change. We go into a lot of detail about a lot of those examples internationally and nationally. So I think that also probably is something for people to think about if they want to get a bit more information about this. But I think really my experience has been that when you start getting into a conversation with this, most clinicians are actually genuinely motivated to move into this space. And what people really struggle with is just that in some cases they feel inhibited by, for example, existing payment mechanisms. And I know like there are obstacles to making this happen. So I think it really, and hopefully there's be a few more change champions out there after this call, but you do really need to fly the flag to really advocate for why having outcomes for people is so important, and really just recognise it's a conversation that you need to keep on having, really.
Certainly, and look, that's certainly been our experience too with the establishment of the Australian Centre for Value-Based Healthcare, that there's a real interest, I guess, in understanding the concepts, having some case studies, and potentially being able to explain those to colleagues. I think there's also, some concern or some level of disparate experience across the health community in Australia around the understanding of terms like commissioning. And we've just had somebody on the line today asking us a question which you might be able to answer, Jay, and that is what the difference is between commissioning for productivity and commissioning for outcomes. And I'm thinking productivity is probably output, but do you have some views on that?
Well, interestingly, I've never come across the phrase productivity commissioning before, but I guess productivity you could measure, to your point, you could either measure it as activity over cost or outputs over cost. And I think really when we're talking about outcomes commissioning, and again, back to your point about the fact you said it's a volume to value equation, I think with outcomes commissioning, the ultimate way that you measure value is by just dividing outcomes over cost. And I think that's fundamentally what I'd say would be different about outcomes commissioning around productivity, because you can be quite productive in terms of the number of occasions of service that you're delivering. So if it's an activity per cost, but what's really interesting is that doesn't necessarily lead to any better outcomes. And one thing I would say is that this is a notoriously difficult space. So I think the Better Access Fund that exists at the minute, when that was first conceived more than a decade ago, it was going to be called the Better Outcomes Fund. But clinicians didn't want to be on the hook for outcomes, so it got renamed Better Access. And so the challenge with outcomes is that any professional working to achieve an outcome for a person only has a relatively limited causal sphere of influence on that outcome. And so what that really makes us realise is that if we're serious about outcomes, we need to look at who else has a causal influence around achieving those outcomes, and that forces us to broaden the conversation outside of healthcare with some other agencies as well.
That's come up very neatly today in the AHHA's release of the Australian Health Performance Framework, which certainly is still focused in on access rather than outcomes per se. Yeah. Look, one of the questions that comes up all the time, certainly not from any of our members who wouldn't dare to do this, nor from any of the listeners who are on the line who certainly wouldn't do this, but what about gaming?
Yeah, okay. So gaming is a really good point. And I've actually, because this question comes up, I've sort of prepared a quick slide on that. So yeah, one of the big challenges with outcomes-based payments, particularly, is that there's a real incentive. So I'll start with cherry picking as the main perverse incentive that we see. And the basic problem is, if you are paying, so say if I take our youth employment example I was talking about before, there are some people who have just come out of university with a first class, top-notch degree, who are going to get a job anyway. And then you've got other people who maybe didn't make it through school. They might have drug problems, they might be homeless, you might have any number of barriers to them getting to jobs. Clearly, a youth employment provider, if you're just paying them to get someone into a job for 6 months, it would be very easy for them to just work with those, degree qualified students who are going to get a job anyway, and actually not work with those younger people for whom it's actually going to be much more challenging to get a job. But that would kind of defeat the whole point of a youth employment program. So this is called cherry picking, or it's sometimes called cream skimming. It's got a few different names, but it's basically a perverse incentive to work with those people for whom it's easier to achieve an outcome. So there's actually a really conceptually straightforward way of dealing with that, and that is basically you risk adjust the payment. So essentially you pay more for someone for whom it's harder to achieve an outcome, and you pay less for someone for whom it's easier to achieve an outcome. And so there's all sorts of analysis you can do in the background to come up with quite sophisticated approaches to payments that make that adjustment. But so I've mentioned 3 other perverse incentives or gaming that often happen. One is goal displacement. So this is the classic sort of hitting the target but missing the point. So it's where you focus on one outcome at the exclusion of others. And so we saw this in England with the 8-minute ambulance target, where people were so focused on ambulances getting to a patient within 8 minutes that you had all these perverse incentives. One as an example was that people started to actually, if they knew they were going to miss the 8-minute target, they actually just went to a different person. And I know it sounds terrible, that actually happened in some cases. So you've got to be really careful that you have a balanced set of outcomes and you're not focused on one outcome, and all you're doing is people will just massage a number of other outcomes and reduce or deteriorate those just in order to achieve that one goal. And then the other 2 gaming sort of mechanisms we see is there's one called the threshold effect, which is basically if you're paying someone up to a certain point, once they've achieved that target, there's no further incentive for them to improve afterwards. And that can, when people are working over multiple contracts, and this is called ratchet effects. It can be even worse because they know if I overperform this year, you're only going to just increase the target next year. So you sometimes see people very specifically not trying to overperform on outcomes. So those are some of the classic sort of gaming mechanisms that we see. And so we really need, if we're moving into this outcomes payment space, we need to be alive to the risks and some of those perverse incentives that often arise.
Absolutely. Thanks for sharing that, Jay. Look, I'll invite the audience, if they want to add a question in on the question and answer box at the bottom of your screen. And while they're doing that, Jay, perhaps you mentioned very briefly that we need to take into account other organisations that impact and potentially can shape the outcomes that can be achieved in a program. Could you talk a little bit more about the social determinants and how we might take those into account in our diabetes scenario?
Yeah, no, that's a really good point. So when we're thinking about the social determinants, so one of the exercises I do when I'm working with organisations to develop program logic is naturally what we tend to think about program logic from a healthcare perspective, and clearly that's what we're here to do. We're health organisations, but most states in the country will typically have an outcomes framework. So in this example, I put the New South Wales outcomes framework. And what that does, that basically says, well, okay, we want to think about the world from a healthcare perspective, but what about from a home, empowerment, safety, social and community, education and skills, and an economic perspective. So, and pretty much government around the world kind of is all looking at those types of broader issues. Now, look, when we're doing our program logics, I really encourage people to actually take whatever the outcomes framework you have in your state is, and actually just line that up along the program logic and use that to stimulate your thinking about how the program that we're trying to commission, how it links in with some of those wider social determinants. And those social determinants can work in two different ways. The first is that there are examples where if we can achieve a health outcome, that's actually going to achieve an outcome for some of our government partners. So the classic, typical example in our chronic disease instance is if we can keep diabetic patients to within safe blood glucose levels, they can maintain their eyesight, they can keep their limbs. Clearly, it's going to be easier for them to maintain employment, particularly if they work in an outdoor active type of job. Thinking about firefighters around the country over the last couple of months as an example. So that's a really good example of how a health outcome can actually achieve an outcome in other parts of government. Because clearly people don't only have health needs, they have needs, like people have needs across all these different parts of government. And also there are other examples where we need to work with our government partners to achieve a health outcome. So in the other example, and taking a completely different example, if you take rheumatic heart disease, which is sort of disgrace and shocking that should even exist in a Western society, but that still exists today in Australia. And it's a completely preventable disease through antibiotics that can be treated and prevented, but young people, particularly in a lot of Aboriginal communities, are dying from this disease. And actually, if you can work with housing appropriately and actually improve things like hygiene and housing conditions, it is a completely preventable disease. But so often, if we're trying to achieve a health outcome, we might need to work with another part of government to actually to achieve that health outcome. So I just think when we are commissioning for outcomes and when we're developing programs of work, just looking at those two-way linkages where we can help our government partners and our other government partners can help us to deliver these outcomes, just makes for a much richer conversation, which ultimately leads us to better cross-agency working and potentially even pooling of funding and co-commissioning in the future.
Thanks, Jay. That leads into one of the questions that we've got up on the screen here from one of our listeners, and that is how we can potentially look at payments that take into consideration attribution across multiple providers. Do you have anything else you'd like to reflect on that? You briefly mentioned pool funding. We know it's hard, but obviously, one of the pathways to dealing with multiple providers.
Yeah, so I think this is a brilliant question. I really like this one because if you're talking about paying and considering that multiple providers might be actually, and sorry, so my light's just got out, but I think you can still see me. If you're looking at, yeah, fine. If you've got multiple providers that are contributing towards an outcome, then what commissioning for outcomes inevitably does is actually encourages us to go and have a conversation with those providers. So given one of these examples, so if we know that we need to work with housing to achieve a health outcome, then by having done our program logic and actually start to understand the issue more deeply, we know that we need to then go and have a conversation with them. And so what this increasingly gets us to be doing as a health system is to actually start thinking about the whole of the government system and actually start monitoring outcomes across government. And look, there are, again, my background's obviously from the English and NHS, and we do things like joint strategic needs assessments in England, where all of government does a collective needs assessment of every single part of government, and then we track outcomes across all of government, and then you have performance dashboards that are actually not just looking at health outcomes, but they're also looking at education outcomes, criminal justice outcomes, and all the different parts of healthcare, recognising that we've got people moving around these different parts of government. So if you want to pay across different providers, then that then leads you to a conversation that in the first instance, that helps you to measure and drive outcomes by jointly assessing a set of important outcomes that are important for all those providers. But it can then lead you to a co-commissioning conversation where you say, do you know what, why don't we start pooling our funding? Why don't we actually start jointly fund these initiatives? Because for this particular cohort of people, we think that's going to best deliver these shared outcomes that we all have an interest in delivering.
We've got a couple of participants who have raised the issue of outcomes data and measurement. So firstly, one asking about the type of outcome data or the lack of outcome data available. They've mentioned in public hospitals, but I think this is true in primary care settings as well, especially for chronic disease.
Absolutely.
They've asked, how long does it take to get from nil to no data to outcome-based commissioning? And the second question, which is kind of related to that as well, is how do we determine key client outcomes for each specific disease? This questioner notes that you talked about a co-design process, but will that be flexible enough for specific patients? And does it pose a barrier at a system level for value-based healthcare?
So interestingly, I might answer the first one first, and you might have to remind me of the second question. Yep. So on the first one, generally speaking, there's a lot more data I would say in Australia in the hospital system than there is in primary healthcare. And then there's a more mature system, but there's still a really long way to go. So I think there are a few. Ultimately, this is a national conversation that needs to be had, okay? So when we think about, for example, in primary healthcare, primary health networks, we have a situation where all PHNs are typically measuring different KPIs, some measuring outcomes, but it's really done at sort of subscale on a PHN by PHN level. I think if you're going to do this stuff properly, you need to move to a national outcomes framework in an ideal world, so particularly for primary healthcare. So there are things happening in primary healthcare. So for example, there's a big program afoot called Primary Health Insights, where they're actually looking to pool all PHN data into a single repository. So the Western Australian Primary Health Alliance are leading this initiative. And once you've got that, once you actually can get data pooled at more of a national scale, then you can actually co-design a meaningful set of outcomes for populations. Because the thing that's crazy in Australia at the moment is that we've got all these different jurisdictions individually trying to work out what are the outcomes that matter, when actually 80–90% of the outcomes are actually quite similar across. So for type 2 diabetes, that's fairly similar. We all know that measuring keeping safe HbA1c levels, that's good, and that's good wherever you live in Australia. So I think this question really leads us into that national conversation about how do we try and, wherever possible, measure outcomes at scale, whether it's at a state level or a national level, because that then enables us to do a whole range of things, and it's a much more efficient way of tracking outcomes. And again, like if you go to the NHS in England, there's the NHS outcomes framework. Okay, so this work has been done in other countries, and so you can actually, and New Zealand similarly. So there are other countries that have actually sort of cracked this to more or less extent. So that's the type of model that I'd be really encouraging Australia to move towards, rather than trying to have to every single jurisdiction trying to work it out themselves.
Yeah, one of our participants on the line today actually is the author of a paper we've recently published on a national framework for outcomes measurement. And I'd encourage people to have a look at that on our website, valuebasedcareaustralia.com.au, if you're interested in that. You did talk about, I guess, when we think about an outcomes framework, we're thinking at a population level though.
Yes.
And the second part of the question I asked you was about whether measuring outcomes can be flexible enough to actually assist in the provision of care for specific patients, for individual patients.
Yes, I love that question. So that's really, really important. Outcomes don't have to be mandated, and they don't have to be the same for everyone. So, and again, leaning on our Smart Skilled Hired example, we actually had a series of outcomes that were client, in that case, for a young person, it was client selected outcomes. So the outcome, in some instances, the outcome for a particular individual might be quite different to the outcome for another person. So if I've just broken my hip, I'm an older person and I'm trying to get back onto my feet, for me, the outcome might be actually being able to walk 200 meters down the road to pick up my grandchild from school. And that for me might be a really meaningful outcome for that particular older person. So I think there is flexibility in outcomes commissioning to actually have client selected outcomes where the particular client can actually say, this is what matters to me, these are the outcomes that matter to me, and you can still incentivize your providers to actually then work towards those client selected outcomes. So I think I love that question, and as an aside, some of the feedback we've been having in Smart Skilled and Hired is that the young people and providers, that aspect of the model is the thing that they probably like the most, is the fact they can actually make it meaningful for the individual.
Thanks, Jay. We've only got a couple of minutes left, and I've got one last question online that I'd like to put to you, and I guess it's kind of a good way for us to finish up as well. And that is, you've talked quite a bit about outcomes commissioning. You've given quite a few examples out of the NHS and other places around outcomes commissioning in primary care. Is there anywhere that our participants might look, and this is possibly beyond the type of services that you provide and that AHHA supports, is there anywhere where people can look to find out more about outcomes commissioning in hospital settings?
Yeah, so I think I mentioned previously the International Consortium for Health Outcomes Measurement. So interestingly, so they are actually looking to map all of the entire disease burden globally. Last time I checked, I think they're about 45%. So they're actually looking at developing outcomes data sets. And interestingly, most of those data sets are very much hospital focused. And in some senses, commissioning for outcomes is actually easier when you think about diseases specifically, and so that is certainly an area where there's been quite a lot of work, but also just mentioning that there are a number of outcomes registers that are being set up nationally and internationally. So in Sweden, they have a heart outcomes register. Victoria, as I mentioned. I've got more information that I can share, and I'm happy to share with participants on this.
Thank you so much for being so generous, with your responses, Jay, and for the presentation today. We do actually have quite a lot of resources available on the AHHA's Centre for Value-Based Healthcare website, and I'll just say that website address again, valuebasedcareaustralia.com.au. We'll be holding webinars on topics related to value-based healthcare most months of the year, and we have done this year, but with the Christmas break coming up, we're going to take a little rest. There'll be no webinar in January, and we'll have some more information on our website fairly shortly about February's webinar. So really just to thank everybody very much. Continue following the conversation with us afterwards on social media as well. Jay, can you just remind me of your Twitter handle again?
It's just Jay Rebbeck. Yeah, so JayRebbeck. So that's my Twitter handle. I'm also on LinkedIn as well. So we'll be responding on LinkedIn after this as well. And just to mention also, that we are running 4 2-day courses with AHHA next year. So we'll put some more information out on that. So, but you can find out about that at rebbeckconsulting.com. But we'll be doing that in conjunction with AHHA.
Yep. So thank you very much, Jay. It's been a great discussion. Thanks to all our participants today too for being so actively engaged. Have a very happy Christmas, all of you, and we'll look forward to connecting with you on social media or next year.
Yeah, thanks so much, Alison, and thank you everyone for joining, and happy Christmas, everyone. It's been a real pleasure.
Thank you very much.
Thank you. Cheers.